Hello, everyone. My name is Kate Marquis. I'm one of the nurses at Life Support Learning Center at the University of Virginia Health, and today I'm going to talk to you about tracheostomy basics. Our objectives today are to identify the differences between normal anatomy and modified anatomy after tracheostomy, identify the difference between the use of a cuffed trach and an uncuffed trach, and to identify emergency actions to take when the airway or breathing of a patient with a tracheostomy is compromised. So, why are we talking about this? Why is it important? Well, tracheostomies have been around since 3600 BC. We actually found evidence of this written out on Egyptian tablets. And it's been utilized throughout the years since. Most notably, it was done by Alexander the Great. Apparently, one of his men was choking on a chicken bone and he had this upper airway obstruction, so he completed a tracheostomy. However, they haven't been all that successful until recent history. If you look at tracheostomies done between 1546 and 1833, there were only 28 successful ones, recorded at least. These were mostly done to relieve upper airway obstructions. However, we got better at it as we move into the 20th century and so forth, especially with the polio epidemic as tracheostomies became more prevalent then. These are more often utilized nowadays for people who are on mechanical ventilation for extended periods of time. You can see on the slide that per Chung and Napolitano, over 100,000 tracheostomy procedures are performed annually in the United States alone. There's some other sources that put that number as high as 110,000. And this overall decreases the mortality of patients on mechanical ventilation and may decrease their hospital stay. Why we're talking about them is that this isn't necessarily just a hospital thing. This isn't people in the ICU that only they'll see it. This can be seen anywhere because people are in fact discharged home with tracheostomies. So they may come back to the hospital. So they may, for our pre-hospital friends there, need to be transported. So you need to know how to work with a tracheostomy. Or maybe this patient is admitted for something completely different. They broke their arm, and now on an orthopedic floor, you have a patient with a tracheostomy. So this is something that is certainly pervasive throughout all patient populations to kind of keep in the back of your head. So I'd like to talk about the normal anatomy before we move into how that anatomy changes. So if you look at the normal anatomy here, you have the oropharynx, the nasopharynx going into the pharynx, to the larynx, into the trachea, and so forth, into the lungs and whatnot. This anatomy gets modified, and this modified anatomy is true for probably 95 to 97% of trach patients that you'll see. So you'll actually see this tracheostomy below the vocal cords and into the trachea itself. And depending on what kind of tracheostomy tube is in place, air can either will only go in one direction. So you can see that this is a cuffed tracheostomy with the cuff inflated. So air can get in through the trach itself, and then it has to come back out through the trach. If you were to deflate that cuff, air would still be able to get up into the mouth and nose there. However, that's not true of everybody. There's this thing called a total laryngectomy. These are mostly done for cancer patients with laryngeal cancer. So this includes the removal of the vocal cords, which will impair the patient's ability to communicate even further than a regular tracheostomy does. Other implications include the loss of the ability to humidify air and the loss of smell. Why is that? Well, if you take a look at that anatomy, there is no track anymore from the trachea all the way up to the patient's mouth and nose. That track is completely taken out. So that has a lot of implications for emergency management because if you look at someone with this anatomy, I cannot bag mask ventilate them in the traditional sense over their mouth and their nose because the only track is their esophagus. So basically, I'm going to go and distend their belly if I were to try to do that. So it's really important to kind of know the patient's history of why they have a tracheostomy tube in the first place, such that you can safely provide care and provide the best care should an emergency arise. This is another picture of that pre-laryngectomy versus post-laryngectomy anatomy there. It's kind of nice seeing the normal anatomy versus the abnormal anatomy right next to each other. So you can really see how that track, as I was talking about earlier, from in the mouth and the nose into the trachea is gone. And now post laryngectomy there. So, what are indications for a tracheostomy? These are not all inclusive by any means, but the big ones here, it's an acute respiratory failure in combination with a need for prolonged mechanical ventilation. It's also a failure to wean from mechanical ventilation in the first place. So, you see these patients who are in the LTACs that they would otherwise be able to go home, but they still require mechanical ventilation. Maybe it's only at night. So, they will still need help there, and they may have a trach for that. Because if you think about it, everything we do has a risk to it. Having a patient intubated for extended periods of time, there's certainly a lot of risks, damage to the airway itself, especially with the cuff inflated for balloons. So trach may be less damaging over time. Other reasons why we put tracheostomies in people, compromised airway of some sort, and you saw this especially if you were looking at tracheostomies that were placed prior to the 20th century, upper airway obstruction. So we talked about Alexander the Great and his buddy choking on a chicken bone there, as well as traumatic and neurologic compromises. So I had a patient, emergency department nurse. She was ejected from the vehicle. She wasn't wearing her seatbelt. She hit the windshield with her face first, unfortunately, and then flew in front of the car many, many meters and hit the pavement with her face and had a compromised airway because of it. So she had a ton of damage, a bunch of Lefort fractures to her face, in addition to other bony damage to other structures. So she was lucky we didn't have to emergently crike her, and we under fiber optic scope, they actually trached her and all that stuff. Neurologic, so we're talking about people, spinal cord damage, so they can't breathe on their own. This may be a prolonged period of time where they might not ever be able to breathe on their own again, as well as strokes and other head injuries may require a trach. Other obstructions include tracheal stenosis. So maybe this patient was trached and they were only supposed to be trached for a short period of time, but now we have this buildup and we actually have a stenosed trachea. So now they need to go in and put in a more permanent one such that this patient can continue to breathe. Like I said, everything we do has risks and ramifications, consequence being an inherently neutral word. Um, But there are always risks that we have when we have patients who are trached. So there's always the risk for airway obstruction, just like with anyone else. Though this one may be more pronounced depending on whether or not um, there's a whole bunch of goop in that trach or what have you, and we'll talk more about that later. Aspiration pneumonia, these patients are at a higher risk for aspiration pneumonia just overall. They're at about an equal risk, thereabouts, of an intubated patient. Again, we talk about tracheal stenosis in Malaysia. Um, and for those of you who may be seeing these patients right when they come to your floor, right after they have the trach placed, so we're looking for infection, fistula, and hemorrhage and bleeding. The big one with the fistula and the hemorrhage and bleeding, there's actually an artery that runs right behind, and up to 3 weeks, these patients, status post trach placement, these patients are at risk for a massive bleed. There are other ramifications to placing trachs in patients. It's one of those things that we really weigh out before we actually place it. So there are going to be some difficulties in communication. So trachs are placed below the vocal cords. So this is going to change how the patient is able to speak, if they're able to speak. In a total laryngectomy, the vocal cords come out. So these are things to think about, especially if you have patients who might be in delirium tremens because they're having alcohol withdrawal. Um, because they have that complication or any other one, really. So, are they able to write? How else can we communicate with these people? These are all things that we want to think about if they're unable to speak to us. It's also changes in the ability to swallow in many cases, so getting speech language pathology on board very quickly and kind of continually monitoring their ability to swallow. These patients have a high likelihood of having aspiration, but on top of that, especially with your total laryngectomy patients, a high risk of silent aspiration, which can be problematic. Finally, there are changes to body image that we need to think about. Now, this is both the patient and the family, and we kind of have to treat them together in many ways, right? The patient is going to look different, right? Even if they get that trach out, there may be a scar there. And then also the family has to adjust to the change in the body image of the patient. This is their loved one, their son, daughter, child, brother, sister, niece, nephew, what have you. This patient is now going to be changed. So I like to talk about the anatomy of tracheostomy tube. This one is a cuff tube, and we'll talk about the differences between a cuffed tracheostomy tube and an uncuffed tracheostomy tube momentarily, but I do want to hit all of the pieces here. Um, First, let's start out with the flange. So the flange is that metal piece you see on your, or that long plastic piece on your screen there. Though trachs may be of varying um, materials, they may be plastic, silicone, polyurethane, or even metal. Old trachs are metal. And in terms of how to use the trach specifically, because you can see that there are multiple components to it, it's really going to be manufacturer dependent. They all generally work the same. It's just how you would remove the inner and outer cannula. But talking about that flange, that long plastic piece there that you can see the tracheostomy ties are attached to, um, I would always be mindful that there's a high potential for breakdown there because that piece sits right up against the patient's skin. So there's this really big opportunity for pretty significant breakdown, especially the longer the patient has this in place. So be mindful of that. You may need to guard against it, putting some sort of Meplex border or what have you on it. And then there are trach ties, and these actually keep the trach attached to the patient. Something to kind of keep in the back of your head. Trach ties get dirty very quickly, especially if um, they're in a new trached patient or newly trached patient there. So if you're going to change out your trach ties, I would make the recommendation that you are holding that flange down because as soon as you disconnect one of those ties, now your trach is loose. And this gives you a high chance for decannulation. These patients often have a really strong cough reflex. So I suggest keeping your hands on that flange and using the other hand to actually change out the ties. Doing that and taking your time doing that. Below that, you can see in the bottom part of the screen there, there's an obturator. So that obturator actually gets inserted into that trach itself, and it makes it rigid, and this allows the outer cannula to actually be placed into the patient. This is also particularly useful for inevitably when the patient decannulates themselves. It allows you to put it back in, though I recommend doing that under direct visualization. The outer cannula is the trach itself. There are multiple flavors of outer cannula. You have cuffed and uncuffed. The difference being you can actually see the cuff there. That cuff balloon has a pilot balloon, so you can see whether or not it is inflated. You're going to be using cuffed trachs for patients who require mechanical ventilation, which will be a majority of these patients. Uncuffed trachs are mostly used for people who have this trach for long term um, because it decreases the erosion that can be caused by the cuff. And even in patients who do require a trach, potentially for mechanical ventilation, I know that with the total laryngectomy patients, we look at taking that cuff down very, very quickly. Think post-op day 1. So in terms of secretion management, kind of makes it a little bit more difficult, but we do try to take that cuff down because of that erosion issue. There are also fenestrated trachs, and what that means is there's a hole in both the inner and the outer cannula, and those are used for people who just cannot be weaned, um, and allows air to kind of move back and forth. In terms of the inner cannula, this is actually placed inside the trach itself, or that outer cannula. And what that is used for is for secretion management. There are two different types of inner cannula. You have reusable and you have disposable. And the names are pretty self-explanatory. The reusable ones, before the patient is discharged, will actually teach the patients how to clean these inner cannulas, um, usually in a sterile technique. And certainly, if you are providing trach care to these patients, you will use a sterile technique. So how to clean that. But for other patients, they may have disposable ones, in which case, if it gets all junky and goopy, they can actually take out that inner cannula and just chuck it. This is an example of a cuff trach. So similar to the picture that I showed you before, you have that pilot balloon there so you can see whether or not that cuff is inflated. Something that I want to point out to you guys is I want you to notice the pathway of the air when that cuff is inflated. The pathway of the air is the air goes in through the down the trachea into the lungs, and back up through the trachea into the tracheostomy tube itself, and back out. It's not making its way up into the mouth and the nose. This is very important to kind of keep in the back of your head, especially as we talk about having one-way valves, which are your speaking valves. And we'll talk more about those momentarily. Now, you can certainly deflate that cuff, and through the deflation of that cuff, now you allow air to go up into the mouth and the nose, much like you would see in an uncuffed trach, which you can see here. I know that picture is a little bright, um, but you can see that air can go in through the trach, and then it can, in fact, if you have that speaking valve on, like this patient does here, can go back out through the upper airway. So, what is a speaking valve? Speaking valve is a one-way valve. So, you can see a bunch of examples here. Air can get in, but air cannot exit via the trach. So, it's like a cap almost. Right? So, I can pull air in through the trach, but I can't put it out through the trach, which is why it is so important that if you have a cuffed trach or your patient has a cuffed trach, that that cuff be deflated. Because as we saw before, if that cuff is inflated, air cannot get past the trach into the upper airway. And if you have a valve on, a speaking valve on here, then the air has no way to exit. So please, 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 if the patient has a cuffed trach, ensure that that cuff is completely deflated prior to placing a speaking valve on. Things that the patient should be able to do prior to placing a speaking valve, they should be alert. So if your patient is sleepy, they should not have their speaking valve on. And they should be able to manage their secretions, because secretion management gets a little bit more complicated if you have something blocking the trach itself. Monitor for decreases in SpO2 or an increase in respiratory rate. Keep in mind that these speaking valves are very expensive, right? They're very expensive and they're not very big. They're very easy to lose. So you can actually see in this picture, there is a leash, so to speak, at the bottom, and you can actually, some of them have this leash that you can connect that one-way speaking valve to the trach itself. They're very easy to lose, they're very expensive. If your patient has one, guard it jealously. I've seen a lot of people lose these, and it's really an unnecessary expense to the patient. Now, they also have caps which are used, which are not necessarily a speaking valve. It's literally a cap that you put over the trach itself. This is used when the patient is being kind of road tested to see if they can have their trach come out. And this will also allow air to escape up through the upper airway. Again, being mindful that if they have a cuffed trach, that that cuff is down. If they have an uncuffed trach, less of a big deal because there's no cuff to impede that air going into their upper respiratory tract there. Other ways people speak, you may see your patient actually just place a finger over the trach itself. It works very similarly. Now allow air to reach the vocal cords and out the upper airway. You're not going to use these on your total laryngectomy patients because there is no upper airway. It stops at the trach. Some clinical pearls from Kate: do not stand directly in front of a patient with a tracheostomy. Some of my peers used to work with learned this the hard way. Even when they weren't standing directly in front of a trach patient, they learned this the hard way. This patient population often has a very strong cough. Now, what do I mean by this? I literally had a patient who we had was in a mostly curtained room, and we were keeping an eye on them, and they had a really strong cough, and they literally hit one of my peers in the shoulder with sputum, and she was no less than 20 feet away. This patient population has a very strong cough, so please keep that in the back of your head while you're selecting your PPE, and I suggest utilizing eye protection. Other things to keep in the back of your head: if you are unfamiliar with the brand of tracheostomy tube, ask the patient how to remove the inner cannula. Airway obstruction is a common issue that this patient population has. So if they have an inner cannula, ask them how to take it out, and they'll actually show you because they are all trained on how to do it prior to discharge. So this patient must be competent in it. Or ask a family member, because usually they have two people. Ensure that they know how to take that trach out. I would also consider humidified O2. Keep in mind that this patient is not bringing air in through their upper airways, their mouth, or their nose, so they're unable to humidify this O2. They're unable to filter all of the things, bacteria and goodness that come in through the air. So if you consider humidified O2, you're humidifying it for them, and that'll help you with secretion management. I want to talk about two selected emergencies here that have to do with the airway. It's decannulation and airway obstruction. So decannulation, this may be inadvertent or intentional, depending on the patient population that you're dealing with. Sometimes patients just cough and out it comes. They were doing trach change, or they were doing a tie change rather, and it just happens. Or it may be intentional, so your patient doesn't know what's going on, they're confused, they're altered. Saw that a lot with my total laryngectomy patients, where we would put mitts on these patients because they didn't know what was happening. Um, so just kind of keep this in the back of your head, that this is not an uncommon thing, or a thing that does not happen often. In fact, 50% of airway-related deaths in the critical care setting are related to decannulation. Why is this a big deal? Because if they take out the trach, there is a high risk of them losing their airway. Now, why is that? It doesn't matter if the patient just got their trach 10 minutes ago, or if they've had it for a couple of years. Eventually, that opening is going to start narrowing and closing. So the highest risk patient population is certainly that patient who had their trach placed 1 day ago, 1 week ago, 1 month ago. However, even established stomas, that opening in the neck itself, right? Even established stomas will start to get smaller over a period of hours. Something to kind of keep in the back of your head. So, questions that you want to ask was: how long ago was the tracheostomy placed? Have they had it for 1 day or 1 year or 20 years or what have you? And how long ago did that decannulation occur? Because the longer it's been, you may actually have to go to a smaller size in order to ensure that you are able to recannulate this patient. We also recommend that recannulation occur with direct visualization. There's a high risk of cannulating the patient in a false trach, which is not going to help them with their airway. So, things to kind of keep in the back of your head. This is a true emergency. Second big issue, or second emergency we want to talk about, is airway obstruction. And this fabulous chart is courtesy of Untempo and Manning 2019. Their article is actually at the end of this presentation. It's fantastic. And they talk about all sorts of emergencies. And they have this wonderful algorithm that we see here. Airway obstruction may occur with mucus plugs, dried secretions, clotted blood, granulation tissue buildup, etc. So, what we want to do is ensure that the patient has a patent airway. If you think about your ABCs, what's the first thing we talk about? A, airway. Do they have one? Right? If they do have one, is it patent? In this case, the airway is not patent, so we need to do something about it. So what we're going to do first is you're actually going to apply oxygen to both the oropharynx and the tracheostomy. Like I said, in like 95 to 97% of your patient population, putting oxygen over the nose and the mouth is going to be totally fine because they have the anatomy that you see here in this picture. Now, if there are any external devices covering the trach itself, remove them because you want to have access to it. So maybe they have a speaking valve on, maybe they have humidified oxygen on, or humidified air on. You'd want to remove that so you can kind of get in there and do what you need to do. If they have an inner cannula, your next step is to remove it because these are for secretion management. So maybe it's just clogged up, it has a lot of goop, something nasty in it, so remove that then. Then you'll move to actually suctioning the tracheostomy itself. That's through the outer cannula. You'll actually go in and suction. This way, if there's goop hanging on the end or out around by the trach itself, you can get all of that stuff up. If an airway obstruction still persists, you'll actually deflate the cuff if there is a cuff present, right? So now we're allowing more space within the trachea itself for air to get in and out, especially through the mouth and the nose there. And then, worst case scenario, you're actually going to remove the tracheostomy. Um, and if you're a paramedic level, you may need to replace it with an intubation. May have to intubate their stoma essentially. If that is outside your scope of practice, I'm not saying do it. Please work within your scope of practice. At any rate, you're going to then uh, bag mask ventilate or intubate as necessary. Right. So what does that look like? Well, in this normal anatomy here, you have two options. So you can actually cover the trach or cover the stoma and ventilate like you would someone with normal anatomy. So you can actually use the bag valve mask over their nose and mouth. Or the other option is to ventilate the stoma. So if you have a pediatric mask, you can put that over the stoma, which it'll fit significantly better. An adult mask will be too big, you'll get a lot of air leakage, so you can actually ventilate that way. Other modified anatomies to talk about, and I spoke about this earlier, I do want to just make a point again. In this anatomy of the total laryngectomy, you are unable to bag mask ventilate the patient over their nose and their mouth. You will need to utilize the pediatric face mask over the stoma itself and bag them there. Thank you guys for spending your time with me. I hope this was informative. I hope you guys have a great day.